Good day, everyone, and welcome. Thank you for joining us today for this Visionix webinar. It is a pleasure to introduce Dr. Pourjavan. Thank you for being with us today, Doctor. Doctor, you are a certified ophthalmologist and glaucoma surgeon practicing in Belgium. You completed medical and ophthalmology training at KU Leuven, followed by a glaucoma fellowship at the Clinique Universitaire Saint-Luc, where you later led the glaucoma clinic. You are currently Vice President of the Belgian Glaucoma Society and work at the Glaucoma Center Zaventem, combining an active clinical practice with research and education. In this webinar entitled OCT Angiography in Glaucoma, Bridging Daily Practice and Emerging Risk Assessment, Dr. Pourjavan, you will present a pragmatic, clinician-oriented approach to OCTA, illustrating how vascular parameters can be interpreted in real-world patients and integrated with structural OCT, visual fields, and clinical findings. The OCT angiography examples discussed are drawn from your clinical practice and research, with acquisitions performed on the Visionix Solix platform. Later in this presentation, at the end, a dedicated time for questions and discussion will be held. So you can all ask the different questions you may have. Dr. Pourjavan, thank you again for being with us today, and the floor is yours.
Hello, good morning. Thank you very much for attending this webinar, and thank you for your interest in science. So I'm going to speak a little about the OCT angiography in glaucoma, trying to bridge the daily practice and the emerging risk assessment. So glaucoma is a challenge. Still, when we are doing the diagnosis, it's just a probability. So glaucoma is symptomless. Diagnosis often occurs very late. And normally we see the patients when they have already a visual field defect. So as I said, the interpretation is variable and it remains partly subjective. It's like having a black box in our brain, and the diagnosis is not always very straightforward. We need different parameters and factors, and sometimes it's very difficult to explain how we got to our diagnosis. So for the diagnosis, we use a structure and visual fields. So this is the structure and function and our clinical context. But that is not all. In glaucoma, we have more parameters that we don't know very well by now. So vascular insights, it's a new parameter that we can use for our diagnosis. There is a need for objective and reproducible and predictive biomarkers, and we need them to diagnose glaucoma, ideally before function loss. What we need for multimodal imaging. OCTA is a non-invasive imaging modality that uses sequential repeated B scans from OCT to visualize retinal and choroidal microvasculature. This is without the injection of the dye. It captures the volumetric blood flow information by detecting the motion of the red blood cells within the blood vessels. OCTA provides depth resolved images, allowing for a segmentation of distinct retinal vascular layers, facilitating precise microvascular analysis crucial for diseases like glaucoma. Motion contrast is not blood flow velocity, volumetric slabs is not the anatomy, and flow signals is not the perfusion. Segmentations shows what we are actually measuring. OCTA does not show the vessels, it just shows the changes over time. So OCTA arrived at the moment that we didn't know how to think with it. We knew how to use it, how to take the images and acquire the good quality, but there was no rule books. There are no rule books to interpret OCTA safely and consistently. I want to be clear that I'm not going to give you a rule book, because there is no rule book. What I'm trying to give you is a framework and how to think with OCTA in your daily practical practices. If you look back to structural OCT, the situation was very different. When OCT was introduced, we already had a mental model about the structure, which was reflecting anatomy. It was a loss or thinning of RNFL. We could see it on our visual fields. OCTA was different. It came with beautiful colors, quantitative metrics, and immediate clinical availability, but it arrived without a shared definition. So we didn't know what was abnormal and what is normal. Without any clear rules, we didn't know about artifacts, and they were all stuffs that we had to learn by ourselves. It was like to learn a new language before we even learned the grammar implicitly. So why the layers matter? Why we have different vascular layers? So let's begin with the first. It's the superficial capillary plexus. Why is it important? Because it supplies the inner retina, and it is vital for retinal health. And it gives us the ability to detect the early disease. In our inner retina, we have the RNFL, and we have our ganglion cell layers, which are very important, and they are the primary structures when there is damage via glaucoma. When we have vessel density loss, it correlates with the loss of our RNFL and the thinning of our ganglion cell complex. Studies show that it aligns with the visual field defects, and it is very robust and reproducible. The clinical value of measuring the superficial capillary plexus is in its early detection. There is structure vascular correlation, and it is enabling us to longitudinal monitoring. This is still not the best validated layer in glaucoma in OCTA. Then we have the deep capillary plexus. As you know, the deep capillary plexus is crucial for the middle retinal layers. It is essential for maintaining retinal function. So the deep capillary plexus, it supplies the middle retinal layers, which are supporting the synaptic transmission. In glaucoma, the deep capillary plexus changes are less consistent. The signal is weaker, there is more noise sensitive, and it is affected by projecting artifacts. The deep capillary plexus may reflect a secondary degeneration or a metabolic stress or transsynaptic effects. We should interpret that with caution. It has a clinical role as a supportive but not primary in glaucoma. It is hypothesis generating, and it is mostly used for research-oriented literature. Then the choriocapillary plexus, which supports the autoretinal and photoreceptors. As you know, glaucoma is not primarily a photoreceptor disease, but it is very interesting because in choriocapillary plexus, there is only a single blood supply. So there is no autoregulatory redundancy when we compare it with the other layers of the retinal circulation. It is very, very vulnerable to perfusion failure, which is very important in the patients with the normal tension glaucoma, systemic hypertensions, nocturnal dips, and vasospastic phenotypes. It is important to see if there is any flow deficit in the choriocapillaries, because some studies showed that when there are some places of capillary dropouts, the progression in normal tension glaucoma is more rapid than when we do not see capillary dropouts. The problem is that even though it is biologically important, it's not easy to measure very reliably because there is depth limited, there is projection sensitive, and it has a high signal to noise ratio dependent. Aging and media opacities makes it still more difficult to make these measurements. I would like to give some attention to the projection artifact removal, which is given by the Solix Optical. So as you know, the problem is that when blood is flowing in the superficial vessels, it casts a shadow or a fake flow to the deeper layers. So what PAR does, it reduces the signals from the copied shadow of the superficial capillary plexus to the deeper slabs, but is still not fully eliminating the projection. And there is some residual artifact persist, especially when you have large superficial vessels or in deep plexus and choriocapillaries. If we do overcorrect with PAR, we can erase deal of deep flow in the retina. So at this moment, most of the studies are based on the superficial capillary plexus, which shown superiority in the studies. So what about the variability and image quality? There have been studies who showed the test and retest variability is very low. It is lower in healthy patients than in glaucoma patients, but still not very significant to take it into account. The same thing about diurnal changes in the OCTA, more important in patients with glaucoma than the healthy subject, but still is not significant to be taken into account in the studies. What is very important is because it's a matching of a motion detection, the quality scores are very, very important. So Solix gives us two quality scores. One is a scan quality score, or SQ, which is derived from signal to noise ratio. And it provides an objective image quality index that correlates with the quantitative assessment of the image. The SKU is very important, and Visionix advises us to use the SKU better or equal of 6. So everything lower than that should be really taken into account cautiously. Then we have another quality indicator, which is the signal strength indicator, which reflects the overall intensity of the signals during image acquisition. It is a basic measure of scan without accounting for noise or signal reliability. So if you have and it has Visionix advises us to use SSIs better or equal of 48. Now, if you have an image that has a high SSI but bad skew, it looks like a loud image, but it is a messy image. If you have lower SSI, but a good image, a good scan quality, is a quiet image, but it is still clean. You should look at the SSI as a sound. So when the SSI is high, it's like you're speaking to someone with a loud voice and they answer you with a lower voice. But the quality of how they are speaking, and if you understand it, is like a scan quality indicator. So lower SSI is less important than better the scan quality indicator. So reliability beats the strength. It is very important because our imaging of OCTA should have good quality images. Otherwise, it's data in, data out. Of course, there are some limitations. There are some technical challenges when you have patients that they have dry eye. The quality image is not good enough. motionless lines when the patients looks to the right or to the left, or they had a bad fixation, so they cannot look the fixating point. It causes limitation and gives us a bad quality. Cataract, opacity, segmentation error of the machine, which is very important to look for it if the machine has done a good segmentation. As I told you, the image quality and SSI is very important, and depth and flaw detection limits are how deeper you go, how more variable or less reliable your image can be. Now, clinically, we have a clinical dilemma. Is there vascular change, or is it a structural consequence? Is there a continuum or a consequence? Do we have first a vascular density loss, which causes RNFL loss, or do we have first some RNFL loss, which has less need for the perfusion, so it causes a vascular density loss? Well, we know that there are some patients that they have first structure loss and then anatomy loss is visible, or vice versa. So it can happen the same thing with vascular density. I do not think that it's important to know the consequence or the continuum. We don't need to solve the causality. We just need to recognize the risk. So when can OCTA add value? Do not forget that OCTA is a longitudinal, meaningful tool. It's not a cross-sectional absolute. So we can use it for our first visit. It is important when you are doing your visual fields and you are doing the OCT, which for the sake of this presentation, I didn't add all the time the visual fields, but do not forget to do your visual fields and then your OCT. It's important to add OCTA as well. So what I do personally, I try to have a good baseline, high quality data, because at the end of the day, glaucoma diagnosis is a multimodal decision making. So I do front loading for my visual fields exam. It means that I do 2 visual fields consequently, so right eye plus left eye, a couple of minutes of waiting, and then again right eye and left eye. So by doing this, based on the studies, it shows that we have less variability and better baseline. Now, recently, I'm doing that the same thing with my OCT and OCTA. So I do, because the Solix, it does the OCT and OCTA, it's faster. So I do my right eye, I do the macula and optic disc, left eye, macula and optic disc. I add some artificial tears without preservatives if needed, and then I do right eye and left eye again. Now, you do not need to have an 3-4 minutes waiting time like as visual field, because the OCTA is fast enough. So I do the right eye and left eye, and if needed, I add, and I do consequently again a second OCTA. So as I told you, it's important to do it at first visit. So this is my for the first time, if I do for a patient, this is what I see on the on my map, and it is important to have an idea. And I just highlighted on the choroidal slabs, if you can see, there are some deeper dots which shows our capillary dropouts. That you can see it here with the vascularization, even on the superficials, the vessel density of the optic disc, and it's correlating with our OCT and optic disc excavation and rim loss. So even here you can visually see that there are some loss of density. So it's important to have a good a high quality image at the first visit. Well, the problem in glaucoma is glaucoma suspect, as we know, because when the patient has glaucoma, there is no problem. But when you have a patient that their visual fields are okay and their IOP are okay and everything is just a borderline, so that is more difficult to have a proper diagnosis. So it is important to have more parameters as possible. As you see here, I have a patient that I have been seeing from 2018 with pressures that they are not totally normal. And sometimes you have some points here that it makes me look at it again and look at it again because they are paracentral and they are important. So when you have these cases, it's much better to have a lot of more information. So this is the OCT of this patient. You can see some small changes of the optic disc, but you can see that they are nearly stable. Same thing for the left eye, optic disc and macula. And as you see, I'm using the vascular vessel density, vascular parameters. I did treated the patients with drops. I was thinking about that, and you can see that the vessel densities are getting a little bit better. So it is important to use OCTA to see if your treatment is had a good impact, because the vessel density gets better when you operate the patient like your OCT values, and if you drop the IOP. We can use OCTA for the later stage glaucoma, but because the problem is when you have a later stage glaucoma, you have the lowest possible values of OCT and OCT on the optic disc and macula. You have your residual floor effect, so that doesn't change a lot, but you can still use your OCTA because the floor effect in OCTA is lower than the OCT parameters. This is just a patient with a nearly black visual field, and on the left side, and you can see that this patient still have a vision of 6/7, and personally he doesn't see it as black. He says that the difference between both eyes is that the left eye is a little bit more blurred. So in these cases, using OCTA is much more important. It can be helpful till the later stages. So I do use, as I told you, OCTA like in trend analysis. Why is it important? Because sometimes it makes me see how should I treat a patient. Is it a patient who is having a fast progression? How old is the patient? How is the general health of the patient? What are the social and familial factors? Because this patient, as you see, is a young patient that is losing not very fast his vascular density, but because this patient is young, it is important. But if this would be a patient of 80 years old, you would think about rate of progression, which is not very fast, and would ask yourself if you should augment the therapy or operating the patient. Then you can take all these aspects into account, if the patient's living alone, if they can come to visit for after operation. So all of this information and all this multimodal helps you to be a doctor and have a personalized conversation with the patient and take the patient into account in his whole and not only his eyes. So it helps you to decide when to operate a patient, especially when the eye pressure is just a little bit higher. And you can see on optic disc of the patient that the left eye is deteriorating fast. So when the eye pressure is consistently not under control, having this biomarker helps you to decide if it's a good patient, if this patient should be operated, yes or not. Which I did operate this patient because of the young age. So as I told you, we can use the OCTA for assessing our efficacy. OCTA can be stabilized or improved when the IOP lowering or after an operation, we have more stabilization. When the trend of the OCTA is slower, there is a slower decline of the patients, and it helps us, as I told you, with a personalized therapy. So it is important to see the OCTA in glaucoma management and monitoring, so establish a good baseline. Conduct serial scans because it helps you to see the vascular decline, so you can be able to detect better the vascular decline. And we should correlate it always with the visual fields to see if there is a correlation. And it's important to look at the thinning. It's not always correlated, but it helps us to see the patient and in his whole and to treat them personally and guide our therapy and prognosis. So our research is using a lot of OCTA. Why? Because it provides a lot of imaging, quantitative data, and these all are a playground for artificial intelligence. So we are trying to use deep learning because deep learning excels at pattern recognition, and it can detect subtle changes that when we are looking ourselves, we cannot see that. And it can help us to enable risk stratification and, as I told you, personalized treatment. So one of the first studies that we did, it was just to write again the inter-observer variability between the glaucoma specialist, highly specialist, coming from the same school. And that showed our first paper, and it showed the need that we have to use an AI-assisted glaucoma screening because of our inter-observer variation. So the second study that we done was first to have a normative value. But a normative value comes with a lot of confounding factors and biases. To have a normative value, we had to find patients without any treatment for hypertension, diabetes, patients who were not using sildenafils, patients who were not smoking, no history of chemotherapy, radiation near to the eyes, because they could all change the vessel density. And then we tried to have enough patients in each decade to be able to see how the normative value changed depending on the age. This was very difficult because having patients of a certain age, normally already after 50 years old, a lot of male patients are using medication for their heart disease, for the hypertension. So it made it very, very difficult to have some patients. So the first study we did is a pilot study because we only had 120 patients. What we are doing now is trying to have a bigger group of patients to validate our study. So again, we used AI to use the combined OCT and OCTA metrics. And what we find out in this small group, that most of the vessel density, especially on the macula and on the optic disc, were decreasing with age. And the difference was very significant when we were around 50 years old. Now, again, the study was very difficult because the vessel density at the macula can decrease having other neurodegenerative disease, and we had to be able to find out if the patient didn't have any Alzheimer's or any decline in cognitive abilities, and it was difficult to find enough patients. So we did another study, and we were using deep learning techniques for OCT and OCTA. And we found out that when we had an intermediate fusion of OCT and OCTA images on the macula and the optic disc, we could diagnose healthy from glaucoma patients. Now, this study was only about healthy patients, but we are currently trying this AI on glaucoma patient after validation of our normative group. What is very important that, as I told you, OCTA on its own doesn't have any value. It is important to a multimodal way of thinking, and what we are trying to do is using OCT, OCTA, visual field, clinical data, pachymetry, gender, to be able to make a multimodal AI for rate of progression assessment. So in our healthy subjects, we found out that we could have a predicted ocular age with our software to define the age of the patients. So that would be a sign of neurodegeneration. Using a multimodal AI could help us to define the rate of progression of the velocity of progression in a patient that we know just for 1 month or 2 months or 3 months, with 1 or 2 or only 3 visual field in a very short time, and not waiting years to be able to assess the rate of progression. So in a couple of words is how we should use OCTA wisely in glaucoma. We should first of all understand the tool. It's a motion contrast, is not direct flow. We should understand the artifacts and projections, which are inherent. As I told you, image quality matters, is very important. We have to choose the right signals. So till now, the superficial plexus is the most robust, clinically validated for the studies. You can use choriocapillaries if you have patients with normal tension glaucoma, but this is not something that you can use a lot in the longitudinal studies at this moment. You have to think longitudinally. Aging matters. The patient shows less vessel density when they are aging, and that causes a variability. Trends are more important as single values, just like the visual field in glaucoma patient, and baseline quality is critical. If you have a bad baseline quality, your trends won't be very correct. Do integrate your OCTA in your clinical decision making, do not isolate it. So OCTA, OCT, visual field, and clinical context are important. Vascular loss by itself is not a diagnosis, it's just some other tool to think about it. which is important at this moment. We do not know how much vascular loss should happen to be important clinically. So that's our studies to come, and to be taken into account in future. So OCTA adds value in selected scenarios. It's not a gadget, it's a thinking tool. So integration beats interpretation. I thank you for your interest in science.
Thank you very much, Dr. Pourjavan, for a very clear, detailed, and insightful presentation, and for the practical advice you shared based on your extensive experience with OCT angiography. I think it really resonated with many clinicians who are interested in OCTA and are looking for clearer reference points to feel more confident using OCTA data in glaucoma assessment. So thank you again for that. We have received several questions from the audience, so I suggest that we go through some of them together. One attendee asked, for clinicians who are new to OCTA, how would you recommend starting to integrate OCTA into the glaucoma workflow, particularly in order to avoid common pitfalls such as artifacts?
Okay, so it is very important to look at your monitor and look for the quality indicators. So the signal quality indicator, or SKU, should be at least 6 or better. Personally, when I have signal quality better than 7, I can really see that that makes a difference. I sometimes look at my quality 5 because sometimes it's very difficult to obtain good images. But when I'm looking at it in trends, I take it very cautiously. So quality indicator 6 is good, 7 is better. And I saw that after 7, the differences are not really significant for me visually. Then the signal strength indicator should not be lower than 48. But again, if you have a quality which is better and you have a signal strength indicator a little bit less than 48, you can look at it and take it into account. Signal quality more important than SSI, but still should try to have at least 48 with your SSI. Then the second thing is how to integrate it. So I advise to use it with your OCT the first time. Do not use it separately, because then you won't see the difference when you are treating the patient in the increase of the vessel density. So you should have to have a baseline point. And to be able to have a baseline point, a good baseline quality, I'm using 2 images. So I'm doing twice my OCT, OCTA. So I have a less variability.
Thank you. We have a related question that concerns interpretation. What are the most common OCTA artifacts or sources of variability that clinicians should be aware of when interpreting vascular parameters?
So one small and very easy overlooked parameter is the dry eye syndrome. So when the patient is focusing the fixation point, they forget, or we do ask them not to blink. Problem with the glaucoma patients is that they are already on different medication and they inherently have dry eye. So what I do is that I ask them if they normally use artificial tears, or I do put some artificial tears before obtaining the images. Second thing is that you have to see that your signals stays in the given space by the machine, because when your signals are very high or very low, sometimes you have a crop image which gives like a black mark on your image. It doesn't change the quality of the image, so you can have a good quality image and good SSI, but with a black space on your periphery of the image. But it's important when you are doing the trend, because that's a black spot doesn't give you any data. So you have to see that you follow the guidelines of the SOLIX when you're obtaining an image. It should be in between the lines that they are giving you.
Thank you. We have another question that addresses this time the overall role of OCT in glaucoma care, which I think you already replied in your presentation, but maybe we could give more details. So the question is, do you see OCTA primarily as a diagnostic tool or more as a method for risk assessment and stratification in glaucoma?
So to be honest, I do not see OCTA as a primary tool, as I do not see OCT alone as a primary tool, as I do not see IOP as a primary tool. As I just mentioned, that's just a multimodal disease that we need everything to be able to make a good diagnosis and a good personalized therapy. We have patients that we do not see any changes of their vessel density nor their parameters of their OCT, but still we can see some cluster and variation in the paracentral region when we are doing visual field testing. So if you were just looking at the OCT or OCTA, we cannot diagnose this patient, or at least we cannot tailor our post-op, consultations to see if there is some real problems. The same things happens that you have patients with the good visual fields, but you can see some loss of OCT or some loss in vessel density. So that is important to take everything into account.
Thank you. We also have received several questions about a very trendy topic that is in artificial intelligence. So what do you see as the main challenges in translating OCT findings and AI-based vascular biomarkers into routine clinical practice?
Okay, first of all, when we are doing OCT and OCTA, we have a lot of parameters that is given to us by the machine. So important is when we are training an artificial intelligence to choose which parameters are more important for a diagnosis of glaucoma. There are some technical methods like PCA, which is a tool that we can use which tells us which parameters are important to be taken into account to train a artificial intelligence. So that can diminish some parameters, but we do need a lot of studies with different parameters to see which one is more superior than the others. Second thing is that we need a lot of data, but a lot of data in normative patients, because although that AI can train himself by himself, just giving him information, it is easier and much better to have a normative base, because then the machine can find the change and find the subtle small variations in between normals and not normals, and to understand if there are some physiological variation or really disease related variation. So as I explained, it's very difficult to have a good base line for healthy patients, because it's difficult to find healthy patients that they are not using any medication and didn't have any major problems. So that is again another major problem. There is a difference in OCT. each machine has a little bit slight difference in the composition of these layers and segmentation. So it makes it difficult to have large studies validated in different places because we are using different OCTs, and the OCTs are not talking to each other. There's a problem of interface that it should be done again with AI. So there is again a lot more data needed to be able to do that. And again, glaucoma is a aging process. We cannot have everything in just 1 year. We need longitudinal studies to make it important. But telling all this, it is important to begin somewhere with it. So as I told you, just when you are doing your OCT, do your OCTA and visual field, do not forget.
And thank you, Doctor. And following on from that, one attendee is asking for a practical illustration. So could you maybe share an example from your research showing how AI-based models might improve risk assessment in glaucoma patients?
So our models are still not validated. It means that we have only my patients and only my normal patients. But in some of the patients that I used, but to be honest, my mind was made before that, is how to see that a young patient could progress in a couple of years. So there are still studies, not only with us, but some studies from the Professor Schmetter's group, ongoing studies that they can show the risk progression in shorter time. So that was a patient that I had a little bit higher pressures, but vessel density loss more important than the OCT parameters loss, visual field stay stable. So we used it in this model, and the model confirmed my own clinical decision that it was better to operate the patient because the visual field would gone worse in 2 years. I would like to emphasize the models that we are making is not to replace me, it's just to help me to make my decision. It is much easier, especially now with all the legal problems that we can have, to have different tools that they confirm your decision. Because the decision making, as I told you in our first publication, is very different in between colleagues who are coming from the same university. So these tools and the AI, just a confirmation of what you should do, not replacing you and not making you become less expert than the machine.
Thank you for this excellent presentation and for taking the time to be with us today and to answer also the questions from the audience. Thank you as well to everyone who joined us today and for the interesting interactions. We hope you found this session useful, and we wish you a very nice rest of the day. Goodbye.